Welcome back to the deep dive. We're here to take those really complex clinical concepts, kind of strip away the noise, and give you the high-value knowledge you can actually use.
Hmm.
Today, we're diving into musculoskeletal trauma. Specifically, we're talking fractures and amputations. It's a fast-paced area.
Absolutely. And that's our mission today, really. A structured breakdown of the pathophysiology and the absolute priorities for intervention. Because when you talk about trauma to bones, joints,
Mhm.
it all comes back to two main things.
Right?
We're always fighting to preserve mobility, and we're always fighting to maintain perfusion. Those are the big ones.
Right, mobility and perfusion. And those two, they pull in everything else, don't they? Like pain management, tissue integrity, sensation,
Mhm.
and always that threat of infection.
Exactly. It's a constant balancing act. Sometimes the very things we do to stabilize for mobility, like putting on a cast, can actually threaten perfusion.
That's the tension.
Yeah.
We need to know where that line is. Okay, so to start, let's lay the groundwork. What exactly is a fracture?
Well, simply put, a fracture it's a break or, a disruption in the continuity of a bone.
Right, a break.
But understanding the type of break, the classification, that's really crucial for anticipating potential complications down the line.
Okay, let's break down those classifications then. First up, by extent.
Right. So you've got your complete fracture. That's where the bone is completely divided, two separate pieces. And those pieces, they might get displaced, move out of alignment.
Which could damage nearby vessels or nerves, right?
Precisely. Then you have the incomplete fracture, which, like it sounds, only goes partway through the bone. It's cracked, but not broken all the way across.
Got it. Complete versus incomplete. What's next?
Next, we look at the skin involvement. Is it closed, sometimes called simple? That means the skin over the break is totally intact.
Okay.
But if that bone fragment pokes through the skin, even a tiny bit, now we're dealing with an open fracture, compound fracture.
And that's a whole different ballgame.
Oh, completely. That visible wound means an immediate, much, much higher risk of serious bone infection, osteomyelitis.
Okay, so extent, skin involvement.
Mm.
What about the cause?
Good question. Fractures aren't always from big traumas. You can have a fragility fracture or pathologic fracture. That happens with minimal stress because the bone itself is weak, maybe from osteoporosis.
Right, I've heard of those.
Then contrast that with a fatigue fracture or stress fracture. That's from excessive repetitive strain. Think athletes, military recruits.
Overuse, basically.
Exactly. And the third cause type is compression fracture. That's from a loading force. Often crushes vertebrae, common in people with osteoporosis too.
Okay, so the bone breaks. How does it actually heal? Is there a process?
Oh, yes. A very defined, continuous 5-stage healing process. And it starts immediately because bone is so vascular. Stage 1, first 24 to 72 hours, is hematoma formation. Basically, a blood clot forms at the site.
Sealing off. Okay.
Stage 2, that clot gets invaded by granulation tissue. This takes maybe up to 2 weeks. And it starts forming fibrocartilage.
So building a framework.
Kind of. The real turning point, though, is stage 3. Usually 3 to 6 weeks in. That's callus formation. New vascular tissue starts surrounding the fracture site. It's like a soft bridge.
Ah, the callus. That's the first sign of real union, even if it's not solid bone yet.
Exactly. Then stage 4, maybe 3 to 8 weeks, that callus gets resorbed and transformed into actual bone.
They're getting stronger.
Right. And finally, stage 5 is consolidation and remodeling. That bone gets reshaped, strengthened, and this can take up to a whole year.
A year. Wow. And I imagine age plays a big role in that timeline.
Huge role, absolutely.
Yeah.
A young, healthy adult, we might see good union in, say, 4 to 6 weeks.
Okay.
But someone over 70, especially if they have underlying issues like peripheral vascular disease affecting circulation. Healing can easily take 3 months, sometimes much longer. We really can't just assume the standard timeline.
Okay, so we've stabilized the fracture, maybe with a cast or surgery, aiming for that mobility. But like you said, there's that tension. What are the immediate life or limb-threatening complications we need to be watching for?
Well, statistically, the most common fatal complication after musculoskeletal trauma or major surgery is venous thromboembolism, VTE.
VTE. So that includes DVT and PE, deep vein thrombosis and pulmonary embolism.
Correct. The trauma itself can trigger clotting, plus the patient is often immobilized, leading to venous stasis. It's a double whammy. So VTE prevention and detection are huge.
Okay, VTE is number one. What else in that acute phase? Infection, obviously, with open fractures.
Definitely. Osteomyelitis. But beyond those, there are 2 really serious, though thankfully rarer, complications that need immediate recognition. Acute Compartment Syndrome, or ACS, and Fat Embolism Syndrome, FES.
Right, ACS and FES. Let's tackle ACS first. You said it's a limb-threatening local crisis.
Exactly. It's a perfect storm of that mobility perfusion problem. You get increased pressure inside a muscle compartment, one of those bundles of muscle wrapped in fascia.
And the pressure comes from?
Could be internal swelling, bleeding from the fracture itself, or external pressure, like a cast or splint that's too tight.
Okay.
That rising pressure starts squeezing the capillaries shut. This kicks off what we call the ischemia-edema cycle. Less blood flow means tissue ischemia, which causes capillaries to leak, leading to more edema, more swelling.
Vicious cycle. More pressure, less perfusion.
Precisely. And that pressure also hits the nerves, causing intense pain.
So recognizing this early is critical. You hear about the 6 Ps for assessment. What should we look for first?
Yeah, the 6 Ps are key, but they happen progressively. The absolute hallmark, the most reliable early sign, is pain. Severe pain, pain that seems way out of proportion to the injury, and crucially, pain that gets worse with passive stretching of the muscles in that compartment.
Okay, pain first. What follows?
Well, often the earliest neurological sign is paresthesia, that numbness, tingling, pins and needles feeling. That means nerves are being compressed. Then you might feel increased pressure. The compartment feels tense, like a drum. You might see pallor, the skin looks pale and cool because blood flow is reduced.
And the later signs, the really bad ones.
Those are paresis, or paralysis, muscle weakness, or inability to move the limb actively. And the very late, very ominous sign is pulselessness, loss of the distal pulse. If you're seeing those, significant tissue damage has likely already occurred.
This sounds like a true emergency. What's the immediate action?
It absolutely is.
Right.
If you even suspect ACS, notify the provider immediately. While waiting, loosen or remove any external pressure, cut the cast, loosen the bandage.
Okay.
And here are the critical don'ts. Do not elevate the extremity. That actually lowers arterial pressure and worsens perfusion.
Right. Counterintuitive, but makes sense here.
And do not apply ice.
Yeah.
Ice causes vasoconstriction, which again further reduces blood flow.
No elevation, no ice. Got it. What's the definitive treatment?
Often it requires an emergency fasciotomy. Surgically cutting open the fascia to relieve that internal pressure immediately.
Wow. Okay, that's ACS, the local perfusion crisis. Now contrast that with FES, fat embolism syndrome. That's systemic, right?
Correct. FES is a different beast entirely. It happens when fat globules from the yellow marrow of a fractured long bone, like the femur or maybe the pelvis, get released into the bloodstream.
Fat globules in the blood.
Yep. Usually happens within, say, 12 to 48 hours after the initial injury. These fat globules travel through the circulation and tend to lodge in the small vessels of vital organs, most commonly at the lungs.
Clogging things up.
Exactly. Impairing perfusion, cutting off oxygen delivery systemically.
So what are the telltale signs if it hits the lungs first?
Respiratory distress is usually the earliest sign. You'll see sudden hypoxemia, low oxygen levels, dyspnea, shortness of breath, tachypnea, rapid breathing.
Okay, breathing problems first.
Then, as the brain is affected, you often see neurological changes, confusion, restlessness, maybe lethargy, even seizures or coma in severe cases.
And is there a classic sign for FES?
There is, but it's often a later sign. It's a characteristic petechial rash, tiny, non-palpable red-brown spots, usually over the neck, upper chest, armpits, and maybe in the conjunctiva of the eyes. If you see that rash with the respiratory and neuro symptoms, that's highly suggestive.
And lab tests would show.
Critically, you'll see a decreased PO2, often below 60 millimeter Hg. You might also see elevated lipids in the blood.
Okay, so ACS and FES are the big acute threats. What about longer-term chronic problems after fractures?
Two major ones come to mind. First is a vascular necrosis, or AVN. This is literally death of bone tissue because its blood supply got disrupted.
Bone death. Where does that usually happen?
It's a big concern, especially after hip fractures, particularly if the fracture displaces the femoral head and tears those crucial blood vessels supplying it.
Makes sense. And the other chronic issue?
That would be complex regional pain syndrome, CRPS. This one is tricky. It's a poorly understood dysfunction of the nervous system, sometimes after even minor injuries.
What does it look like?
It causes severe, persistent, often burning pain that seems way out of proportion to the initial injury. Plus, you can get weird autonomic symptoms, like dramatic changes in skin color, temperature, sweating, and swelling in the affected limb. It can be really debilitating and frustrating for patients.
All right, shifting gears to assessment. In an emergency, when someone comes in with a suspected fracture, what's the priority? How do we approach it?
Swift and prioritized is right. First, get the history, especially the mechanism of injury. Was it a crush, shearing force? Acceleration, deceleration like in a car crash,
Why is the mechanism so important?
because it tells you what else might be injured. A high-impact pelvic fracture isn't just about the bone. You have to think major blood vessels, bladder, bowel. It guides your whole assessment beyond just the obvious break.
Okay, anticipate associated injuries. Then what?
Then it's always ABCs first. Airway, breathing, circulation. Especially with major fractures like the pelvis or femur, the risk of massive internal bleeding and hypovolemic shock is very real and needs immediate attention.
So, manage life threats before focusing on the limb. Check for shock, internal bleeding.
Absolutely. Look for blood in urine or stool. Check for abdominal rigidity or tenderness. Assess all major systems.
Once the ABCs are stable, then we focus on the injured limb.
Yes. And the absolute cornerstone of limb assessment is the frequent, diligent neurovascular assessment. We often call it CMS checks. Circulation, movement, sensation.
CMS. And you have to compare it to the other limb, right?
Always compare affected to unaffected. Check skin color. Is it pale, dusky, mottled? Temperature. Is it cool? Can the person move their fingers or toes distal to the injury? Can they feel light touch? Are the distal pulses present and strong?
And checking sensation. You mentioned paresthesia being an early sign of ACS.
Exactly. Any change in sensation, any numbness or tingling is a red flag that needs immediate investigation. These neurovascular checks need to be done repeatedly, especially early on.
Okay, assessment done. How do we confirm the diagnosis and what's the initial care?
Diagnosis is usually confirmed with standard x-rays. For more complex areas like the hip or pelvis, a CT scan might be needed to see the details. And if we're worried about ligaments, tendons, soft tissue damage, an MRI is the way to go.
And in the field or ER, initial care?
Call 911 if you're at a hospital. Support the injured part. Don't try to realign it yourself. Remove any jewelry from the affected limb immediately before swelling starts. Check that neurovascular status distal to the injury.
Right.
Then immobilize it. Splinting is key, and you need to immobilize the joint above and the joint below the suspected fracture. If there's an open wound, cover it with a dry, sterile dressing if possible.
And once they're in a controlled setting, what about non-surgical management?
Often, the first step is closed reduction. That's manually pulling the bone fragments back into alignment.
Does that hurt?
Oh, yeah. It requires pain management, often moderate sedation. And because we're using sedation, we absolutely must monitor their oxygen saturation and, importantly, their end-tidal CO2, or ETCO2.
ETCO2, why that specifically?
Because ETCO2 gives us a real-time look at their ventilation, how well they're breathing out carbon dioxide. Opioids and sedatives can suppress breathing, so monitoring ETCO2 is a critical safety measure during procedures like closed reduction.
Okay. Safety first with sedation. After reduction, it needs to be held in place, right? Immobilization.
Correct. Often, initially we use splints rather than full casts. Splints allow room for swelling, which is expected in the first few days. A cast put on too early can become too tight very quickly.
Leading to ACS.
Potentially, yes.
Okay.
If a cast is applied, whether it's the faster-drying synthetic kind or the older plaster type, which takes 24 hours to fully harden and needs careful handling with palms, not fingertips, to avoid pressure points, those neurovascular checks become even more critical, hourly for the first 24 hours.
Hourly. Wow. And what do we teach patients about cast care?
Key things. Report any hot spots under the cast areas that feel unusually warm or painful. Could be pressure necrosis or infection starting. Keep the cast dry. And the absolute #1 rule, never ever stick anything down inside the calf to scratch an itch.
Ah, yes, the coat hanger danger.
Exactly. You can break the skin, lead to serious infection. Tell them to use a hairdryer on a cool setting. Aim down the cast if itching is bad.
Good tip. What about traction? When is that used?
Traction is basically applying a pulling force. It can be used to help reduce a fracture, maintain alignment, or sometimes just to relieve muscle spasms and pain, especially before surgery.
Are there different types?
Two main types. Skin traction uses weights attached to the skin via straps or boots, like buck traction, often used for hip fracture muscle spasms. Weights are usually light, maybe 5 to 10 pounds.
Okay.
Then there's skeletal traction. This involves inserting pins, wires, or screws directly into the bone and then attaching weights. This allows for much heavier weights, like 15 to 30 pounds, for more significant fractures.
Pins in the bone. Sounds intense. What's the safety priority with traction?
Absolutely critical. The weights must hang freely at all times. They can't be resting on the floor or the bed. And those weights should never be removed or lifted without a specific provider order. Removing the weight can cause misalignment or severe muscle spasm.
Okay, let's transition now. Sometimes, despite our best efforts, trauma or disease progresses to the point where a limb can't be saved. We need to talk about amputations.
Right. Amputation is the removal of a body part. And while trauma is a major cause, especially in younger people, the most common reason for lower extremity amputations, particularly in older adults, is actually complications from peripheral vascular disease, PVD.
So, poor circulation leads to tissue death. Our perfusion concept again.
Exactly. Lack of perfusion leads to gangrene, non-healing ulcers, intractable pain, and amputation becomes elective, planned surgery to remove the diseased tissue.
When planning an amputation, what determines the level? How high up do they go?
The surgeon's goal is always to remove all the dead or diseased tissue while preserving as much functional length as possible. There's a huge effort made to preserve the knee joint whenever possible.
Why the knee specifically?
Because a below-the-knee amputation, a BKA, requires significantly less energy expenditure for walking with a prosthesis compared to an above-the-knee amputation, or AKA. Preserving the knee dramatically improves the potential for future mobility.
Makes sense. More natural mechanics.
Yeah.
What are the specific complications we worry about after an amputation?
In the immediate post-op phase, hemorrhage is a major risk. These are major surgeries involving large blood vessels. So monitoring for signs of hypovolemic shock is critical.
Okay, bleeding first. What else?
Infection, of course, is always a risk. Then, longer-term issues can include the development of a neuroma. That's a sensitive little tumor made of damaged nerve endings at the end of the residual limb, which can be very painful.
Ouch.
And another big one, especially with leg amputations, is flexion contractures. That's where the hip or knee joint gets stuck in a bent position due to improper positioning or lack of range of motion exercises. This can make fitting and using a prosthesis impossible.
Contractures sound preventable, though.
Largely, yes, with proper positioning and early mobility. But perhaps the most challenging complication for the patient, psychologically and physically, is phantom limb pain, or PLP.
Ah, PLP. Feeling pain in the part that isn't there anymore. That must be incredibly confusing and distressing.
It is, and the absolute nursing priority is to validate that experience. Recognize and state clearly that the pain is real. Never, ever tell a patient, it can't hurt, the leg isn't there. That undermines trust and prevents effective treatment.
So acknowledge the pain is real. How is it treated? Is it different from regular post-op pain?
Yes, it often is. Because PLP is largely neuropathic, related to nerve signals, standard opioids are often less effective than they are for incisional pain.
Interesting. So what does work?
We use different classes of drugs. Sometimes high-V calcitonin can help in the first week post-op. For dull, burning phantom pain, beta blockers like propranolol might be used. For sharp, stabbing, pins and needles, neuropathic pain, anti-epileptic drugs like gabapentin or pregabalin are often the go-to.
Okay, specific drugs for specific types of PLP. Are there non-drug approaches?
Absolutely. Mirror therapy can be very effective, using a mirror to create a visual illusion of the missing limb moving, which can sometimes calm the nerve signals. TNS units, massage, biofeedback too.
Got it. Now, quickly back to trauma. If someone has a traumatic amputation, say, a finger severed in an accident, what's the emergency care for the part itself, if reattachment is possible?
Good point. For the patient, direct pressure on the wound and elevation. For the severed part, first, gently rinse off any gross contamination if possible, but don't scrub. Wrap it in dry, sterile gauze.
Dry gauze, okay.
Then place the wrapped part inside a sealed plastic bag. Then put that bag into a container with ice water. The recommended ratio is about 1 part ice to 3 parts water.
Ice water, not direct ice.
Critically important. Never place the severed part directly on ice. That causes freezing injury, frostbite, to the tissues you're trying to save. The goal is to cool it, not freeze it.
Dry gauze, sealed bag, ice water bath. Got it.
Okay.
Post-op care for the residual limb. What's key for eventual prosthesis use?
Number 1 is monitoring perfusion to the remaining limb. Checking skin warmth, color, and the pulse, just proximal to the amputation site. Then preventing those contractures.
Oh.
A firm mattress is essential. And for lower limb amputees, we need to counteract the tendency for hip flexion contracture. This means having the patient lie in a prone position flat on their stomach for 20 to 30 minutes, several times a day, usually every 3 to 4 hours.
Prone positioning. Okay.
Yeah.
What else helps prepare the limb?
We need to prepare it for weight bearing and also help decrease phantom limb sensation. One way is teaching the patient to push the residual limb down towards the bed surface. Start with a soft pillow, then progress to a firmer pillow, then finally the firm mattress itself.
Toughening it up, desensitizing it.
Exactly. And the final piece is shaping the limb for the prosthesis. We need to reduce edema and create a conical shape. This is done using elastic wraps applied in a figure-8 pattern, tighter distally, looser proximally, or by using special shrinker stockings or sometimes rigid removable dressings.
We're covering a lot of ground. Let's briefly touch on a couple of other specific high-risk fractures before we wrap up. Pelvic fractures, you mentioned them earlier. What's the overriding concern there?
Hemorrhage, massive hemorrhage and hypovolemic shock. The pelvis houses major blood vessels and organs, and it bleeds profusely when fractured. Assessment is laser-focused on signs of internal bleeding, checking blood pressure, heart rate, urine output, looking for abdominal distension or bruising, blood in urine or stool. It's a potential killer.
Okay, pelvic fracture is high risk of bleed. What about vertebral fractures, particularly those compression fractures?
Right, vertebral compression fractures, VCFs. Very common with osteoporosis. They cause intense back pain, loss of height, and limited mobility. Often managed non-surgically with pain control, bracing, physical therapy.
But sometimes that's not enough.
Correct. For persistent pain, there are minimally invasive procedures like vertebroplasty or kyphoplasty. Basically, bone cement is injected into the collapsed vertebra to stabilize it and relieve pain. Kyphoplasty uses a small balloon first to try and restore some height before injecting the cement.
Interesting options. Okay, let's pivot slightly to something maybe less traumatic, but very common repetitive stress injuries. Carpal tunnel syndrome seems like the classic example.
It absolutely is. Carpal tunnel syndrome, CTS, is the most common type of repetitive stress injury. It's all about compression of the median nerve as it passes through that narrow carpal tunnel in the wrist.
And what causes the compression?
Usually swelling or thickening of the synovium, the sheath surrounding the flexor tendons that also run through the tunnel. This is often linked to jobs or activities involving repetitive wrist movements. Think assembly line work, typing, data entry, increasingly even heavy cell phone use.
Makes sense. What symptoms should make someone suspect CTS?
The classic triad is pain, numbness, and tingling paresthesia in the distribution of the median nerve. That's the thumb, index finger, middle finger, and the thumb side of the ring finger. The pain is often worse at night. Weakness, especially with pinch grip, can also occur.
Is there a quick test for it?
A common provocative test is the Phelan maneuver or Phelan wrist test. You have the patient flex their wrists fully, pressing the backs of their hands together for about 60 seconds. If that reproduces their symptoms, the tingling or numbness, it's considered a positive test and suggestive of CTS.
Okay. Prevention seems key here. What can people do?
Ergonomics is everything. Proper workstation setup, keyboard height, chair support, mouse use. Taking frequent breaks from repetitive tasks, doing wrist stretching exercises. Sometimes wearing wrist splints, especially at night, can help keep the wrist in a neutral position.
And if conservative measures fail?
Then options include NSAIDs for inflammation, corticosteroid injections directly into the carpal tunnel to reduce swelling, or ultimately surgery. Surgical release involves cutting the transverse carpal ligament to open up the tunnel and decompress the nerve. It can be done endoscopically or via an open incision.
All right. And just to round things out, for general acute soft tissue injuries, bad sprains, maybe a knee injury, a rotator cuff tear in the shoulder, what's the immediate go-to protocol?
The old standby, RICE-E. It's still the first line of defense. Rest the injured part. Ice application for the first 24-48 hours to reduce pain and swelling, usually 20 minutes on, 20 minutes off. Compression with an elastic bandage to provide support and minimize swelling. And elevation of the injured part above the level of the heart, again, to help reduce swelling.
Simple but effective.
Yes. But always remember, especially with significant pain or inability to bear weight, always assume it could be a fracture until an x-ray proves otherwise. Don't just assume it's only a sprain. #outro. You know, listening back to our conversation, that theme just keeps coming up, doesn't it? That constant interplay between trying to stabilize from mobility while ensuring we protect perfusion.
Absolutely. It's the core tension.
And whether we're talking about recognizing those subtle early signs of ACS or FES, or implementing the correct positioning to prevent contractures after an amputation, or even managing something complex like phantom limb pain. It all requires that vigilant focus on circulation and function. Critical thinking is just non-negotiable.
Well said. And critical thinking often means knowing what not to do, right? So let's leave our listeners with a practical challenge. Circling back to that critical complication, acute compartment syndrome. What are those 3 specific actions you must absolutely never take if you suspect ACS because they'll make the perfusion worse?
Right? The 3 don'ts. Don't elevate the limb. Don't apply ice. And don't leave that tight cast or bandage in place. Loosen or remove it immediately while getting help.
Don't elevate, don't ice, don't leave it tight. Crucial takeaways. Critical thinking applied. This
Mhm.
has been a deep dive into musculoskeletal trauma. Thank you for joining the last minute lecture team.